everyone. We're going to go ahead and get started. This talk is entitled Me Too in Emergency Medicine, a discussion of gender, racial, and sexual minority discrimination and harassment in medicine. I'd like to take a minute to introduce my co-presenters, Dr. Michelle Lall, an Associate Professor of Emergency Medicine at Emory, Dr. Ava Pierce, an Associate Professor at UT Southwestern, Dr. Dave Liu, an Assistant Professor at Maine Medical Center, Dr. Nick Hartman, an Assistant Professor at Wake Forest Emergency Medicine, Dr. Sheryl Heron, a Professor of Emergency Medicine at Emory, and I'm Jennifer Mitzman, an Assistant Professor of Emergency Medicine and Pediatrics at Ohio State. Thanks.
Okay, well, thank you all for being here. We know we're at the bitter end of the conference, so we appreciate you all very much. So as Dr. Mitzman said, we're going to review discrimination and harassment in medicine. We're going to talk about a pilot study that we performed and some conclusions and next steps. So to start with, we're going to kind of start with some history here. So Me Too, this was started with Tarana Burke, who's a social activist and community organizer, and it started in 2006, the hashtag Me Too. But it was really popularized by actress Alyssa Milano on Twitter in 2017. And the movement kind of started with those in Hollywood at that time. And the Me Too movement is a movement against sexual harassment and sexual assault. So it's in the House of Medicine. So the women that are photographed there in the FIG scrubs that have Time's Up healthcare on the side. And then we have some of our allies in the other window who've been speaking up about Time's Up in healthcare. And remember, this applies not just to physicians, but to our nursing colleagues, respiratory therapists, social workers, all of those who are part of the healthcare setting. So there was a report that was done by the Academy of Sciences, Engineering, and Medicine, and this is a huge consensus report. This is like a 125-page document that really outlines the sexual harassment of women in the STEM fields. And in this, they report that 30% of female physicians are sexually harassed on the job. 33% of nurses have experienced physical violence and bullying, and 25% have been sexually harassed. And more startling, 50% of female medical students will have experienced harassment before they graduate. So gender discrimination in medicine is generally talked about in 4 different areas. There's salary, advancement, recognition, and then assessment. So this is data from Medscape, and this is a comparison of compensation between men and women. And it shows you the percentage disparity based on age. Here, this is, again, a trends in earnings. So men are the blue line, women are the red line, and you can see that men have always out-earned women, and this is healthcare professionals. And you can see the gap narrowed a little bit in the late 90s, and it has broadened back out by 2010. There are lots and lots and lots of studies that show this. We have reproduced this now many times. This study by Lasasso was one of the first ones, and they found a $16,819 pay gap. And this was for newly trained physicians in New York. And you can see on the side there all of the different things that were adjusted for in this study. So this one took it a step further. This is Dr. Jenna's study that was in JAMA. And this was over 10,000 physicians at 24 public medical schools. And you can see they adjusted for even more variables in their study. And the pay gap held. I'll let you guess whose earnings are the darker shade. That's right, it's the women. And the men are there in the lighter blue. $19,878 difference in salary. But if you look on the bottom there, emergency medicine, because the study by Jenna et al. Was multiple specialties, emergency medicine didn't seem to fare that badly, about $6,700. But wait a minute. So this was a study that was performed by many physicians who are at this meeting. It was 2015 survey data of the academic programs, 47 departments, 1371 full-time faculty. So here it is. There are all of the things that we adjusted for. And as you can see, in academic emergency medicine, we found a difference of $19,462 between men and women.
So why does this matter? If you have been at any of the other conferences in terms of lectures today, you have seen this unfortunate leaky pipeline time and time again, where women in particular are increasing in numbers in terms of applicants to medical school, but slowly but clearly attriting when it comes to moving forward in their academic attainment, from residents to faculty to full professors and to deans. And so these realities are things that we must pay attention to and continue to ask the questions, why? This study also, interestingly enough, looked at mustaches. As you can see, men there with mustaches compared to women leaders, and sadly, it still showed that women accounted for 13% of department leaders at the top 50 NIH funded medical schools, and men with mustaches accounted for 19%. I'm not sure if I would look pretty attractive in a mustache, but I would hope that we would not use these tongue-in-cheek studies that, although they display the realities of what women have to deal with when it comes to these sorts of discrepancies. And speaker introductions at internal medicine grand rounds. This particular study was also looked at to see what bias existed in terms of how women were introduced at conferences. And I can tell you my own personal account and what you've seen of others when it comes to who gets addressed formally as physicians, men versus women versus not. And as you can see here in this particular study, speaker addressed by professional titles that male to female, you can see a great disparity in how women are introduced. And it's not just at internal conferences as well, it's also in the social media and other areas in which we see these discrepancies. Looking at the ACEP awards from 1970s to 2010, you can see initially there were no awards for women, as you can tell, the light blue being men, but slowly over time we started to see an increase in awards awarded to women, but clearly not where we would want it to be. And looking internal to our house at SAEM and the percentage of women who were awarded significant and prestigious awards, you can see the number of female winners for the prestigious John Marks Leadership Awards and the Excellence in Research Awards. Sadly, the Hal Jane Award for Excellence in Academia over 24 years have had no women physicians. And thanks to the AWEM, as many of us are members are, we have been able to deliver 100% of awards to women, which speaks to the value of organizations that are representative of and inclusive of women. Another study from JAMA looked at the comparison of male versus female resident in milestones, looking at evaluations specifically to emergency medicine. And you can see the number of programs that were included, the number of direct observation evaluations in terms of men and women who were being assessed. And sadly, as you can see, over time, by the third year, and this are PGY3 programs, women were evaluated in all 23, lower in all 23 EM subcompetencies for both procedural and non-procedural milestones, which really begs the question of what's happening, why are these disparities existing, and more importantly, what can we do and what will we do about it?
We see that similar trends exist when we look at racial and ethnic discrimination in medicine. Minority residents looked at their views on the role of ethnicity and race in their training experience in the workplace. They noted three major themes: that they were barraged by daily microaggressions and bias, they were tackled with race and ethnicity as ambassadors, and they had challenges negotiating professional and personal identity while being seen as other. Addressing these challenges related to race and ethnicity is crucial in creating an inclusive environment for our learners. We also found differences in words that were used to describe racial and gender groups in medical students. While whites were frequently described as standout, exceptional, outstanding, blacks were described as competent, females were described as caring, compassionate, empathetic, bright, and organized. These systematic differences in how candidates were described based on racial, ethnic, and gender gaps clearly show us some implicit bias in the process. We also note implicit bias in medical school admissions. Capers and McDougall at the Ohio School of Medicine had 140 of their committee members of the admissions committee take the black-white implicit association test. All groups displayed significant levels of implicit white preference. Men in faculty had the largest bias measures. 67% thought that the IAT might be helpful in reducing bias. The class that matriculated to The Ohio State University College of Medicine that year was the most diverse in its history. Racial disparities also exist in AOA. Black and Asian medical students were less likely to be inducted in Alpha Omega Alpha than white counterparts. These small differences can result in clinical performance and amplify differences in grades and awards. Tarani looked at 200 in 2013 and 2016, found that URM students received half as many honors grades as non-URM students, and that URM were 3 times less likely to be selected for Honor Society membership. He documented that this was an amplification cascade, where small differences in assessed performance would lead to larger differences in grades and awards, and ultimately the career that these people might be able to have, the specialty they might be able to pursue, and the residency program that they might be able to attend. Where the rest of us, improving representation in minority faculty in academic medicine, shows that most URM faculty depart at the level of assistant professor because of lack of career and professional advancement and low salary. They feel that they have racial and sexual harassment that leads to them departing from academic medicine. Healthcare workplace discrimination also leads to physician turnover for those underrepresented in medicine. LGBT physicians still document discriminatory care of LGBT patients, disrespect against the partners of those patients. They heard derogatory remarks about LGBT patients and had felt like they had been socially ostracized themselves. 15% in 2011 document that they had been socially harassed and harassed by colleagues. And what are medical students experiencing in this setting? They feel that anti-LGBT discrimination still exists, often feel like it's originated from actually medical students that they're matriculating with. Still in the closet, the invisible medical minority, in 2014 looked at 1,300 osteopathic medical students. They said that they still felt that they had higher levels of depression, slightly lower levels of perceived social support, more discomfort when disclosing, and the campus climate still was not inclusive. The anti-trans memo published in the New England Journal of Medicine in 2019 discussed the 2018 Department of Health and Human Services memo to redefine gender as a biological immutable condition determined by genitalia at birth. This effort would restrict federal non-discrimination protection for transgender people seeking medical care. Damaging repercussions for transgender and intersex Americans could happen if this happened. So clearly, the discriminatory behavior still exists for sexual minority and race and ethnicity.
So understanding sort of the landscape of gender, race, ethnic, and sexual minority sort of discrimination in medicine, we wanted to do a pilot study looking at what is the current landscape of this in emergency medicine, specifically academic emergency medicine. So this wasn't actually included in our initial description for this didactic because we didn't know if we were going to get data in time, and in no small part to one of our collaborators in the audience, Tanya Strout, we were able to pull data together over the last month to really present and show you what is the current landscape in emergency medicine now. So we did a pilot study that was cross-sectional, community sample of EM faculty at 6 sites, so Emory, Northwestern, Maine Medical Center, UT Southwestern, and Wake Forest. University of Washington is highlighted in red because that data is still forthcoming, so we haven't incorporated their data into this analysis. So what you're going to about to see is really just the 5 sites. It hasn't included UW's data yet. So we did a survey that occurred sometime between February and March of 2019. The survey was anonymous, and we made it anonymous so that people would feel free and at liberty to disclose some pretty sensitive and important topics here that they may not otherwise be comfortable doing. All EM faculty at all of these sites received the email invitation for the survey that was administered through Qualtrics, and up to 3 reminder emails were sent to non-responders. All of the IRBs that were relevant were approved the study, including Maine Medical Center. So our primary outcome for this survey pilot study was the perceived discrimination scale score. So this was a scale developed to measure perceptions of discrimination based on gender, We then adapted the same questions to fit race, ethnicity, and also sexual orientation. So what does this actually ask? So this is, how strongly do you agree with the following statements about your current place of work? So where you currently are. And it's 5 questions. I have been treated unfairly at work because of my gender. The people I work with sometimes make sexist comments or statements or decisions. I feel that some of the policies and practices of this organization are sexist. At work, I sometimes feel that my gender is a limitation. And at work, I do not get enough recognition because of my gender. Each item is asked on a 1 to 5 Likert scale, with 5 being strongly agree, 3 neutral, 1 is strongly disagree. And you add up these scores, so the scores for this PDS scale range from 5, the lowest, to 25, the highest. So what were the results? So we got about 136 faculty, again at the 5 sites, not including UW yet, about a 45% response rate, and about 60% male, 40% female in our pool. The mean age for our respondents was about 41 years old, and the majority are about 1 to 5 and 6 to 10 years out of residency, but there is a nice spread of faculty from all spectrums of their career. In terms of race and ethnicity, the majority of our respondents were white, about 80%. The rest are as listed. For purposes of statistical analysis, because the number of specific minority groups were so small, we decided to dichotomize our results into white and non-white later on, when you'll see when we did statistical analysis. Similarly, we did the same thing with sexual orientation. So the majority, 90%, were identified as straight heterosexual. The rest are as listed. And for statistical analysis, we dichotomized it to straight heterosexual versus not straight heterosexual. All right, so the first primary outcome we looked at was the PDS scale score, the perceived discrimination score by gender. Again, a reminder, ranges from 5 to 25, 25 being the highest. And women EM faculty reported an average score of about 15.4 versus men at 10.1, and this was statistically significant. So remember, there were 5 questions each, and about, if you look at the averages, that means on average, the typical female faculty member would have answered each question about 1 point higher for each of the questions on the PDS scale. We also asked them, in my current institution, I've experienced discriminatory treatment based on my gender. And if you look at the categories here, we see that women were statistically significantly more likely to report it on a weekly, monthly, annually across categories compared to men. We also found that their experience with gender discrimination at their institution correlated with their PDS score, which makes sense, right? So the fact that you've experienced these experiences means that you then perceive higher rates of discrimination. So that kind of makes sense. We then asked the people, so the people who answered weekly, monthly, or annually, we want to find out what was the source of these discriminatory treatments. So the majority actually reported patients, and they averaged about monthly occurrences with patients, followed by consulting or admitting physicians from other services, as well as nursing staff. There was sort of discrimination from all sources, but the other ones as listed became a little bit more rare. So we then asked them, in my current institution, I've observed, so not experienced personally, but I've observed discriminatory treatment of another physician based on gender. And if you look at it by category here, you notice that there was actually no statistical difference between men and women in their instances of seeing discriminatory treatment of another physician based on gender, which is kind of surprising. So the men and women were equally likely able to identify cases of discrimination based on gender by observation. This again also correlated with the PDS score, which is not surprising. So the fact that you see more of these episodes makes you think that yes, the perceived discrimination score is higher. And again, we asked them people weekly, monthly, annually who have observed this. What was the source? Again, the top 3 were the same. Patients, number 1, followed by nursing and consulting physicians. We then asked people, in your professional career, so not just at your current place of work, in your professional career as a physician, have you encountered unwanted sexual comments, attention, or advances by either a work superior or colleague. So this could encompass any time when you were a medical student, a resident, a fellow, or current attending. We didn't specify exactly when, so they were at liberty to say whenever it happened in their medical career. And you'll notice that women reported that over 50% of them reported that yes, they had encountered unwanted sexual behavior during their medical career. Men reported yes to about 25% of them, 27.6% of them reported yes, for an overall percentage of about 38% of physicians had encountered unwanted sexual behavior at some point in their medical career. What was interesting is when we then looked at some more sort of advanced analysis, controlling for gender, we found that the older you were and the more years out from training you were, the more likely you were to report yes. And we didn't really figure out exactly why based on the gender. So it could be because you've had more years in the profession and therefore you've had more experience or time to experience these things, or maybe times have changed and maybe it was more common to have these experiences earlier on than currently. That remains unclear because we didn't ask in that survey. So for people who answered yes, men and women, the 48 who answered yes, we asked them, what was the actual unwanted sexual attention or advance that you've received in the past? And this could be cumulative. So the vast majority, thankfully, were the sort of less aggressive behaviors like sexist remarks or behavior or unwanted sexual advances. But you'll notice that not an insignificant amount reported coercive advances, subtle bribery to engage in sexual behavior, and threats to engage in sexual behavior. These people we then also asked, what was the impact of these unwanted sexual attention and advances on both your confidence as a professional and also on your career advancement? About the majority again said none at all, which is, I think, makes sense with what the data showed earlier in terms of remarks versus more aggressive forms of behavior. But you'll notice that about 22% from somewhat to greatly reported a negative confidence on of these advances on their confidence, and about 15% reported somewhat moderately in terms of a negative effect on their career advancement. And Nick is going to continue with our data.
Good afternoon. Let's continue our look at the survey data now with respect to race and ethnicity. As you can see, we had 100 survey respondents who identified as white and 25 who identified with other racial and ethnic categories. As Dave mentioned, we categorized respondents in this way because many of the groups were otherwise too small for meaningful analysis. There was a significant difference between these two groups in terms of the perceived discrimination scale, with non-white respondents reporting a greater degree of perceived discrimination based on their race. And recall again that the PDS ranges from 5 to 25. This slide shows the distribution of responses for white and non-white participants as to whether or not they had experienced racial discrimination at their current institution. There was a significant difference in responses based on race, with non-white respondents reporting more frequent discrimination. This also correlated individually with responses to the PDS questions. This shows the sources of racial or ethnic discrimination for respondents who reported weekly, monthly, or annual instances of discrimination. Patients were again the most frequent source of discrimination. This does raise one possible area of question about our categorization, namely that we included persons of Asian descent in this group. While people of Asian descent are not considered underrepresented minorities in medicine, they're likely to be considered minorities in society at large, and so likely vulnerable to the sort of discrimination noted here from patients. One other item that should be noted is that these rates of discrimination, thankfully, are reported at a less frequent rate than gender discrimination in our data. Depicted here is the frequency of observing discriminatory treatment on the basis of race. Interestingly, there was not a significant difference between white and non-white respondents in this domain, leaving open the possibility that white faculty are just as likely as non-white faculty to observe discrimination. This finding did significantly correlate on an individual basis with the findings in the perceived discrimination scale. Let's transition to discrimination on the basis of sexual orientation. Again, these data are grouped together into non-sexual minorities and sexual minorities of all types. As shown here, respondents identifying as sexual minority were significantly more likely to report discrimination on the basis of sexual orientation as opposed to non-sexual minorities as measured by the perceived discrimination scale. Again, the range is 5 to 25 on this scale. Similar to the responses for racial and ethnic minorities, sexual minorities reported more frequent discrimination at their current institution, and responses to this correlated with the PDS. Also similar to the data for racial and ethnic minorities, there was not a statistically significant difference in respondents' report of observing discrimination on the basis of sexual orientation, meaning that non-sexual minority respondents may have been just as likely as sexual minorities to observe this discrimination. The PDS did correlate with individual answers to this question again. So in terms of some of our conclusions for the overall study, our pilot study showed that women, racial and ethnic as well as sexual minority faculty perceive more discrimination in their workplace than their counterparts. The perceived discrimination scale correlated with reports of actual experience of discriminatory treatment. Interestingly, we did not observe a significant difference among groups in observing discriminatory treatment. This should be a challenge to all of us, including those who do not identify with one of these minority groups, to speak up and advocate when we observe instances of discrimination. As they say, if you see something, say something. And further, we found that approximately 50% of female and 25% of male EM faculty encountered unwanted sexual comments, attention, or advances at work. This was correlated with age and years out of training. As Dave mentioned, there are a couple of ways to interpret this. It may be that older faculty simply had more time to have these experiences. We hope that it could be a reflection that workplace environments are improving in this regard, though clearly there's a long way to go, as demonstrated by the negative impacts that we found on confidence and career advancement.
So in summary, we noted significant perceptions of discrimination that existed on the basis of gender, race, and sexual orientation. As Dr. Hartman and Dr. Liu pointed out, the observation rates were not affected by whether or not the individual was of male or female gender, whether they were white or non-white, or whether they identified as heterosexual or straight or not. And so it becomes apparent from this data that it is incumbent upon all of us to speak up when we are observing these things, because all of us at similar rates are able to identify these kinds of inappropriate behaviors in the workplace. Similarly, while those who are affected by being part of a minority group, they reported higher levels of experience, they did not report higher levels of observation. In terms of next steps, there are several that we wanted to focus on. One relates to patients and how they interface with the data that we collected. As you saw presented, patients were a source of a significant number of unwanted sexual advances, gender discrimination, racially inappropriate comments, etc. And so while it's important for us to engage with one another as healthcare professionals in talking about this, I believe that a very important next step is also to begin to engage with patients and the public to ensure that this kind of behavior declines over the course of our practicing lifetimes. Also, consultants and nursing staff were identified as areas where there are kind of more of these comments and unwanted advances, and so including them in the conversation and considering targeting educational interventions or other types of interventions to mitigate these behaviors is another valuable next step. And lastly, I think that we hope that we will begin making movements towards what people should be doing when they experience or observe these behaviors. We saw a lot of data presented by all of our panelists about the existence of this, and so moving from the phase of quantifying and describing that, yes, this is a real phenomenon that our medical professionals are living and experiencing, and making steps towards what are we going to do about it. Thank you, and we'd like to entertain questions or comments if people have them.
I'm going to actually ask Sheryl a question. Are you surprised by the numbers? Because I'm relatively new to this sort of area of top area of discussion. So I myself was quite surprised by the numbers, but I might be quite naive about it too. So I'd love to get your perspective.
So I don't know if surprise is the right response versus saddened, actually. Inherently, I think I knew, and perhaps we all knew, that this happens. But when you start to collect data and see it happening, writ large, right in front of your face, it, quite frankly, sort of empowers one to really step up and do things. And I commend both Dara and Esther for really trying to push forward this Time's Up movement, because it still seems to fall on ears where people believe that this does not happen. And when you think about the impact of this on one's ability to be successful, gratefully, the verbal comments we have been able to, by what was presented, somehow move forward. But I do worry and wonder at the continuation of seeing this and experiencing this time and time again, how we become numbed and acceptance towards some of these behaviors, and how really that would manifest in people being productive. So it's more saddened and disappointed, probably not as surprising as I would have anticipated.
I have a question.
Oh, good.
I thought that was great. My name is Anwar. In a comment and a question, the first comment is with the second part where you presented your own data. I thought that one of the more surprising findings to me was that everybody sees the discrimination, right? And I think what that does is it lays the groundwork for prescribing, like what you say when you see something, right? And I think that you probably couldn't get to that in this survey, but I feel like that's next. But my other question is about in the first part of the survey where we were talking about the types of discrimination for us as professionals. Those studies ranged over the past 15 years or so, and it's the same problem that's redisplayed. Do you think, or does the panel think that the issue is that not enough programs know that this level of discrimination is going on, or is it that the things that people try to put in place are ineffective to fix it? Or maybe both. Does that make sense?
It does. I mean, I do think that, I think that one of the things I found most interesting about this data is that, as you said, right, there's many observers of this behavior, but we clearly don't have a culture yet where people feel comfortable to say something most of the time. But I think the other thing I found quite interesting is that the kind of, I guess, almost lack of the apathy from the people that had experienced this, they were just kind of like, it didn't affect me. And I think that's because this type of harassment and discrimination is still culturally normative in the United States. And I think that is, that's just part of it. Right? I think, as a woman, you learn probably as a preteen girl that somebody's going to say something to you and that it's best just to walk away. Don't engage. Don't try to make a big fight. Right? You could get yourself hurt. Something worse could happen than just getting a cat call or something else that is sexually inappropriate. So I don't know if that points a little bit to your question. I do think that programs maybe don't appreciate that it's going on, too. You know, I mean, medicine is a hierarchy, whether we want to believe that or not still, right? I know hospitals and healthcare systems have worked incredibly hard to create cultures around safe patient care where anybody can say something, right, including the person from environmental services who is cleaning up the room, that they should feel empowered to say something if they think the patient is at risk. But we've never really done that for ourselves. You know, and certainly in our clinical environment, I try to call these things out in real time, even from patients, you know, that your behavior is not appropriate. We won't tolerate that. But we're also bound by EMTALA and litigation and other things to still take care of people, where in any other industry, if they came in and were acting this way in a restaurant, the police would take them out, and it wouldn't matter, right? But I could still be sued because I didn't take good care of you even though you were threatening me, verbally, maybe even physically.
So Michelle and I actually shared in a very misogynistic presentation by a senior leader in our institution. It was appalling, to say the least. And we sat back as leaders in this movement on equity and inclusion, and we said, and it was at one of our grand rounds, and we said, we've got to say something. We literally said we cannot sit back, given our passion and interest and knowledge on topics as sexual, and this was verbal sexual assault, I promise you, and not say anything. But even as leaders in this, we had to strategize time zero to think about how to do this in a way that whether that individual received the information or not would be reflective of us as a department not tolerating this. And it really manifested in us, time zero, going up to that individual together, because you don't want to do this by yourself, you want to have allies, speaking of our subject matter expertise on these topics and the leadership that we both have, and called them on it. And it felt not really good. It was somewhat embarrassing because we knew that this sort of conversation had been happening for decades. And he actually said that. I've given talks like this. Why are you so upset? You know, I've given these talks and no one has said anything. So we're at a different time and space now where we must say something. And to the point about the patients, it's now compelling individuals to go home and look in your respective departments and hospitals on what policies are there and or need to be developed on how to respond to discrimination and sexist remarks that come from your patients. And so I know there has been work, and we've been asked at Emory to think about it and what we need to create, because in trying to look for these sorts of things, they frankly don't exist. And so I would ask you, I don't know if anyone else has had the need to or has tried to find what the response is on a systems level for these sorts of things in terms of patients' egregious behavior and the environment that's been created, but it's definitely something to think about.
I also think that you know, no institution is all good or all bad, right? They're made of lots of individuals, and so taking that into consideration, that, you know, it's going to be a process. You know, I work in an institution that, for example, I did have a relatively recent opportunity to look up kind of what were my rights when a patient who was in need of a laceration repair continued to touch me inappropriately, and what were my options in terms of saying, you know, this is a cosmetic procedure, I have screened you from a medical legal, like, for any emergencies, and you don't have one, so you don't get to be here anymore. But I also work in an institution that unfortunately today published a pretty horrifying report about sexual misconduct on the part of one of our faculty members in the 70s, 80s, and
90s that went unaddressed by the institution for close to 30 years. So recognizing that we are, a sum of many parts, and that there's a lot of work to be done, but that there also are improvements continuing to be made, and it's not all, hopeless and dark either.
Hi, I'm Sheryl, I'm at Emory. So my question was largely answered already, thank you, but I did have one other part to the question. So as far as sexual advances in the workplace, I'm sorry if I missed it, but I don't know if you touched on kind of the percentage of who were the perpetrators of the sexual advances, so patients, colleagues, or superiors. And then my question was really just about patient care, and if patients are the ones making these sexual advances, how do we go about that? So thank you for touching on that. I don't know if anyone else has additional comments as well.
So I can comment on the first part of the question. So the data looked at all instances of sexual advances, so we didn't specify for that particular instance who was the source. So it was all cumulative, so we can't identify how many came from patients versus colleagues versus your boss, your medical director, et cetera, et cetera. But we did find out that for the majority of cases, I would say the most common source was patients for both comments and also behavior, and followed by, I think, consulting physicians or admitting doctors, and then nursing. Those were the top three in both categories.
So not everybody turned it in. Do you guys have an idea of how prevalent this might actually be, among people not answering?
No. I mean, I don't think we have a way to answer that, but I think, if you look at trends from other industry, right, it typically starts with one individual, right? Like we can take Harvey Weinstein as an example in Hollywood, right? It started with one woman who then turned into over 20, I believe, right? So we know that there's more than what's reported, but how much more, we don't know, right? And 2 days ago, there was another set of allegations that came out of another academic emergency medicine department in this country. So I think we're naive to think it doesn't exist in our own shops. It just may not have reached sort of that societal normative level where it's finally enough that somebody says it's enough. Often all these verbal comments and things aren't really enough. Somebody gets a warning, they go to conflict management, sexual harassment training, some kind of online course that the department will put somebody through to remediate them in this area, but that's likely really insufficient.
Hi, great talk. I would say two things. One, I think it's obviously disgusting that all this stuff happens. And two, I think it's awesome that a relatively small part of it comes out of our house, that it's mostly from the consultants, patients, you name it, but it's not the emergency medicine. There's obviously some of it that's still out there, but it's a relatively small proportion, and I think that's somewhat heartening. The other thing is, what I would say, I'm kind of curious, in what I've seen personally firsthand is, I can see something small. I can see something small that's, as a straight white male, I'm not on the receiving end, but I see something that's a little bit off. And then, but it's a lot of times when you see something that minor, it's hard to go and, throw a fit or report it up the chain of command when it's, something that seems inconsequential. But then later on, after the fact, you find out that there's been a pattern of behavior that's a lot worse, and that was just maybe the tip of the iceberg. Do you have any suggestions for that sort of situation?
Yeah, so I think that's a really, you make a really great point, right? A lot of times, especially in the emergency department, we sort of see what we're doing in isolation, right? We see it as one single encounter, one single event. And so sometimes we fail to recognize these patterns. And the example that Dr. Heron gave before, actually ended up to launch something much, much larger and revealed this really horrible pattern of behavior in an individual for quite some time. So, you know, I do think it's important to document it somewhere. I can say I just had an encounter with an orthopedic attending, and I sent it to my medical director. I said, listen, I don't know if this is in isolation, and it might be, but in case it's not, here's what happened. And the next day, I got a call from the chair of orthopedics because it was not in isolation. So I think we just need to feel empowered to say something. And if it, you know, it never feels good, but I do think it can be prefaced as, I'm not sure if this person's just having a bad day. This may be an isolated event, but in the case that it's not, I think you should be aware that this happened. And if you can keep things very, you know, objective, I heard the patient say blah, 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 or I heard Dr. X say this, you know, then it's not you being judgmental, subjective, anything else. You're just reporting the facts as you heard them. And I do think that that helps. I think, too, that I appreciate your comment about ally behavior because that is, I think, the most important thing that can happen. It's certainly far more empowering when the patient says something, you know, kind of inappropriate to me, and a male nurse, a male tech, a male physician corrects the behavior. We know that that ally behavior has often more impact than for me to say something like, sir, you're inappropriate, or you may not speak to me that way. It would mean a lot more if Dave was next to me and said it. So I think we just have to empower one another to say something, and as educators to create an environment where especially our trainees, our learners, our junior faculty feel like they can say something to us. You know, and I was for my department sort of the voice in a very drawn out process against 2 of our surgeons. But I was willing to be that voice. I had not been impacted by either of these people, but my junior colleagues had and my trainees had.
So I want to give another example just to your question. So a couple of months ago, I was, you know, I work at Maine Med, and we were in a trauma room, and paramedics delivered a patient, gave report. I was with a senior resident who was about to graduate in a couple of months, and, you know, usually they give report and they say any other questions, and in this case, the paramedic said any other questions miss, or I forget what exactly, but it wasn't doctor. And I sort of, something about that just sort of like alerted me, like, oh, you always say doctor with everybody else. Why did you just say miss? So I know this paramedic. This is not someone I think is, you know, a misogynist or sexist in any way. So in sort of after the report was done, I kind of met him outside, said, hey, I noticed that when you gave your report, you asked Dr. Wakeman, like, miss. And when I talked to him about it, he said, oh, I didn't even realize, like, I'm sorry. Like, and I said, oh, yeah, just so you know, that's what I noticed. And I think, you know, in the future, it might be, you know, beneficial to treat everybody the same way, address everybody the same way. And what was interesting was, well, I talked about it with the resident afterwards, and I mentioned it to her, and she says, and I said, did you notice that he said any other questions miss as opposed to doctor? And she says, yeah, I know, but anyways, that's okay. And I'm like, no, this is not okay. Like, you're so used to it. And kind of to Michelle's point about most of them said it didn't bother them at all. I mean, it's kind of like 1,000 paper cuts, right? So eventually it does impact you. So I think instances like you don't have to sort of make it a big thing every single, you have to be a judge of, you know, what necessitates what kind of a response. In that case, it seemed to have worked a little bit. And the resident was extremely appreciative that I even noticed it and then maybe addressed it, so.
So recently at my institution, we had an incident where a patient got really belligerent and was yelling really loud, awful, racial, anti-black slurs, and had to be kind of, we call it a takedown, like she was a psychotic patient. And one thing that my white female colleague did, one of my co-residents, she turned to me and says, you know, you don't have to be involved in this. You don't have to be here. You know, I can deal with this. You can step away. Kind of recognizing that, like, you know, that this is clearly triggering, and it was coming from a really good place, and I appreciated it. But it also was kind of, it felt weird to me because the reality is, the entire security team was black. You know, one of the attendings was black. And there's many times at my institution where it's me, my Muslim co-resident, and my black attending, and the mostly black nursing staff. And so the reality is there isn't always going to be that white guy ally who can kind of swoop in and save the day. And so there needs to be some kind of institutional procedure in place, or just a way for kind of reporting. And I mean, it's a little bit easier when you have patients that are psychotic or need to be restrained, or, you know, you can kind of write it off that way, or when patients get physical, there's procedures in place for that, but there's no real procedure in place for just kind of the patient who says, I don't want you as my doctor, or who someone is just nasty in a very targeted anti-racial or anti-gay way. You know, and it's a tricky situation. I know a lot of times the response, you know, when it's a physical issue, it's more police presence, and even that is, you know, both positive and negative in many ways. So it's a weird situation, and I'm not entirely sure what the answer is. But I did appreciate my colleague recognizing this was particularly triggering in a specific way for me and some of the other people on the team.
You make a great point that it is like there's so much power in just the acknowledgement that it happened, right? And you're right, it's not, you know, the person who's like frankly psychotic and swinging at everyone, like we have an answer for that. At least we do in my department. Security comes, they get held down, and they get chemically and physically restrained, right? And nobody questions your judgment about that. It's often the patients where it's more subtle, right? Well, are you sure you're the supervisor? Yes. Isn't there a man doctor? No. Well, who was that I saw? That's the medical student. Please, he can come back and speak to you. That's fine. Right? I mean, it's in the more subtle ways where we are obligated to do our medical screening exam, and it's amazingly challenging when the patient's actually kind of sick. Right? When they're not sick, it's easy. You don't have an emergent medical condition, and you will be discharged now. It's when they're sick, or when you know there's something that really needs to be worked up or addressed, that's when it's hard. Because now you're trying to play the game of being professional, upholding your Hippocratic oath to take care of somebody, but you also have to be very aware of what's happening to you, and we shouldn't have to tolerate it in our work environment. So it's hard. But, you know, I'm sure your colleague, I don't know if you told her, but you should, that you appreciated that she had your back, right? Because ultimately, that's what maybe helps with the death by 1,000 paper cuts, right? Is to realize you have some allies that'll put a Band-Aid on it, even if they didn't have the right solution.
Thank you.